I'd like to welcome you all to the Cummings School of Medicine. We will have some people arriving a little bit late, probably due to our wonderful roads, but I think it's so important that we do begin on time because we have a very exciting and packed day. So my name is Jennifer Hatfield, and I'm the Associate Dean for Strategic Partnerships and Community Engagement here at the Cummings School of Medicine. This is a day for sharing inspiration and wisdom as we move to create together and strengthen a compassionate Calgary. I have the great honor of standing before you to represent a great team that put this event together. And it's a collaboration. I just had a lovely moment with John Meddings, who I'll invite up here in just a moment to do our formal welcome. And I said, it feels like Christmas, and it really does. We've been planning and excited and pulling people together, and I cannot tell you how thrilled I am to see all of you here. But now I would like to ask our Dean, John Meddings, to open up our proceedings for today. John.
So thank you, Jennifer. And let me just echo your words. I am really, really excited to see everybody here. And I'm incredibly proud, actually, that the Cummings School of Medicine can host this. So I'm here to formally welcome you all to this event, Street Cred and Social Medicine. Imagine a compassionate Calgary. And what a wonderful thing to imagine. I mean, for so many reasons, this is the right thing for us to be doing. So Street Cred stands for Street Community Capacity in Research, Education, and Development. And it's a partnership that we're incredibly proud of to be part of here at the Cummings School of Medicine. We share a vision of social accountability, of responding to health needs of underserved people. And the goal of today's event is to exchange knowledge, to share with Calgary some of the leading approaches to harm reduction, social determinants of health, and chronic care for the inner city population. And what truly could be better than that? Because out of that, better healthcare comes, better societies come. So I'm delighted this morning to have some of Canada's top thinkers and practitioners in the field as our speakers. You're going to hear some outstanding people today. Jeff Turnbull is going to talk. Jeff is an Order of Canada recipient, and he established and studied the first managed alcohol programs in the country. And I've known Jeff for some years. He was the chair of medicine at the University of Ottawa, and I was the chair of medicine at the same time for that somewhat nasty city to the north of us at the University of Alberta. And I have to say, since meeting Jeff at those meetings, I have become Jeff's biggest fan. And so Jeff, totally looking forward to having you here. Jeff inspired another speaker, Dr. Naheed Dosani, to found the PEACH initiative in Ontario, or in Toronto. PEACH, Palliative, Education, and Care for the Homeless. And our third speaker is Dr. Meili, who's the Division Head of Social Accountability for the College of Medicine, University of Saskatchewan, and he's the founder of a group called UPSTREAM, very appropriate name. It's a not-for-profit organization focused on the social determinants of health. I think all of us in this room know that one of the primary reasons why people are healthy or not healthy is actually not the healthcare system. It is the social determinants of health. So this evening, UPSTREAM is partnering with Street Cred to host a free public event in the Libban Theatre. And our Global Health Concentration medical students have organized a pavilion for that event with over 25 community agencies in attendance, and I hope everybody is going to manage to join us there. So I'd like to thank our partners in Street Cred for their contributions to these events and for the work they do each and every day. I'd like to name them. So the Alex Community Health Centre, the Calgary Drop-In Centre, the Mosaic Refugee Clinic, the Elbow River Healing Lodge, and CUPS, which is a wonderful one. I just mentioned to one of the directors of CUPS, it's near and dear to my heart, having had a daughter who spent several years working with CUPS. So I'd like to thank all of you for all of your partnership and all of the wonderful things that you do. I'd like to thank particularly Jen Hatfield, actually, for the work that she has done to set this up. Jennifer has taken on a social accountability mandate within the School of Medicine that I think is wonderful and is doing an outstanding job. Bill Galley, I haven't seen Bill, but I'm sure Bill is here. He's the leader of the O'Brien Institute for Public Health and incredibly involved in this. Charles Leduc, who I think I saw a little bit earlier, who is a very engaged department head for family medicine and endlessly supportive of these events. And also to Martin Labrie and Bonnie Larson, who've worked incredibly hard on this initiative. And finally, all the student volunteers and the students in attendance, I'd like to thank all of you for coming. If the coming School of Medicine is going to be relevant to the communities we serve, it's important that we not only talk about it, but we do what we say we're going to do. And having our students here from our Bachelor of Health Sciences program, from the School of Medicine, is incredibly important. So thank you for doing that. I hope that this is going to be a great day. In fact, I don't hope, I know it's going to be a great day. Thank you all for coming.
Thank you. Good morning, everyone. My name is Andrea Hull. I'm a family physician here in Calgary, practicing at the Mosaic Refugee Health Clinic and also the Elbow River Healing Lodge. It is my pleasure to welcome and introduce Dr. Ryan Meili today. I met Ryan at medical school in Saskatoon. His passion for health equity and global health interests quickly made him stand out and become a leader among his peers there. He has continued to progress and accomplish much in his career since then already. Dr. Meili is a family doctor at the Westside Community Clinic in Saskatoon and assistant professor at the College of Medicine, University of Saskatchewan, where he serves as the head of the Division of Social Accountability. Dr. Meili is also a co-lead of the SHARE, Saskatchewan HIV/AIDS Research Endeavor. His 2012 book, A Healthy Society, How a Focus on Health Can Revive Canadian Democracy, has sold over 4,000 copies and helped stimulate a political dialogue around using health in all sectors approach to developing policy. Ryan serves as Vice Chair of the National Advocacy Organization, Canadian Doctors for Medicare, and he is the founding director of UPSTREAM Institute for a Healthy Society. It is my pleasure to introduce Ryan Meili today.
Well, good morning, and thank you, Andrea. It's a real treat to see you, a U of S fellow grad and pal, and lots of other familiar, friendly faces in the room. So thank you very much for inviting me. And I find that, well, first of all, I find it's important to declare that my biases are multiple, but they're not remunerative for me in any way. So no commercial interests whatsoever. I find it's always helpful to spend a little bit of time when meeting new people, spend a little time around the campfire, say who you are and where you actually come from. I'm a farm boy from southern Saskatchewan who somewhere along the line got interested in social justice and global health, and have been fortunate enough to have lots of mentors along the way who encouraged me in those interests. And that has led me to experiences in Brazil, India, Mozambique, which you see here, as well as working in northern Saskatchewan, all over rural Saskatchewan, and my current practice in inner city Saskatoon, where I work at a clinic called the Westside Community Clinic. And we serve a population that is largely First Nations and Métis, some refugee population speaking Spanish. I have Colombian and Mexican families that come for care with me, and then exclusively, really, people who have issues with income, who have lower incomes, and who have other social challenges. And that work is very rewarding and extremely engaging, and every day exciting to go to work. It's also work that can be extremely frustrating, because the reality is, well, we don't necessarily get the tools in our medical training to actually know how to work with populations like that. And that may be because the tools don't even exist, or they're not in what we would traditionally think of as our role as physicians. So traditionally, this is the kind of advice that we give people. And it's good advice. I certainly tell my patients to stop smoking, work very hard on that, talk about cutting down on alcohol, exercise, all of those, the holy trinity of health promotion, and all of these other really great tips. It's good advice. But when you look at this list, and I like this list for a number of reasons. This list shows us the social determinants of health compared with other elements of what goes into whether we'll be healthy or not. And you don't really see that previous list on there. The things that make the biggest difference are actually how much money we make, how far we go in school, what those 1,000 first days of our lives are like, other social factors. The other reason I like this slide is it breaks it down into the numbers. It shows you just relatively how much impact healthcare has in comparison with those social factors. And this is probably even a little bit generous to healthcare in terms of what the studies do suggest. But we recognize that, most of our efforts go into, and most of our funding goes into doctors, hospitals, pharmacies, nurses. Really, that's not the most impactful. And the other reason I show this slide, and this is a shout out to Dr. Turnbull and the work that's been done at the CMA. This is from the Canadian Medical Association, which in the last decade, under the leadership of presidents like Jeff, has really gone in a direction of becoming strong advocates for health, and in particular for addressing the social determinants of health, which I think is a sea change in my experience since the CMA that I saw during my training to the current pattern, which is really much more encouraging. So if we're going to take those social determinants of health into account, this is the advice that perhaps we should be giving our patients. Don't be poor. Pick better parents. Have a car, have a decent job, have a safe place to stay, access good food. All of these things that are obviously phrased in a bit of a tongue-in-cheek way, but you can see how that puts into relief the difference between the advice that we give people, which is so focused on the individual, and what really has an impact, which is much more caused by our collective realities and the policy environment in which we live. Another way of phrasing this was very succinctly put by the famed pathologist Rudolf Virchow. Virchow was anyone who's been in medical school learned about Virchow's triad and Virchow's node, but he also was a politician. And he said that medicine is really a social science and politics is nothing but medicine on a larger scale. And that quote has certainly inspired me in some of my advocacy activities, but also causes me to ask some questions. What if we see politics as medicine on a larger scale? Do politicians see the same thing? Do they look at themselves and say, I'm really a physician for this population. My job, my primary purpose is to improve their health. I think if they did, we'd see this kind of approach, health in all policies, where whether it's a decision made in health or in justice, transport, education, any of the ministries or departments, the question would be asked, is the decision ahead of us going to improve health or make it worse? And that we would preferentially make those decisions that improve health. It makes a lot of sense, right? Almost so much that you would wonder, doesn't that already happen? But I think this slide really shows what the reality is, which is, this is the Canadian Index of Well-Being. So that's a numerical measure of basically the quality of our lives. Health outcomes, educational outcomes, amount of people in the justice system, our democratic engagement, the health of our environment. And it's compared here to GDP. And what you see is a massive growth in the last decades in the economy of this country, but very little of that translating into actual improvements in the quality of our lives. So if this is the goal, if economic success is the primary goal and that's all we're trying to achieve, whopping success, we're doing really well. If politics is supposed to be medicine on a larger scale, this is malpractice. Right? We're not doing it right. We're failing to translate the gains economically into real improvements in our lives. So why do we look at that? Because I think it demonstrates the current frames, economics as the most important thing, austerity mindset, and the need for a new frame. Frames are the terms of argument, and if you're in that existing frame of economics as the most important thing, the response to the response might be, well, here's a better plan for the economy. But that limits our possibilities. It limits what's available in the so-called Overton's window of political options. We need a new frame. And what I've been proposing through Upstream and a healthy society is this idea of health as our frame. And I propose that for a few reasons. One, it's something we care about. Our language is full of references to healthy appetites, healthy debates, and that interest in health is reflected constantly in Canadian pollings. This is a poll or a study from the most recent federal election and looking back at elections all the way to the early 90s. And that green line at the top is healthcare, always that issue of most importance to Canadians. So it's something that matters to us. It's also something that's meaningful. If you take the World Health Organization's definition, not just the absence of illness, but full physical, social, and mental well-being, and can you think of a better motto for what we'd want to try to achieve as a city, as a province, as a country? So we have something we want to achieve. We have a destination that's meaningful and measurable. We can see whether our health is improving or not. And we have a roadmap on how to reach it. When we look back to that list of social determinants of health, ranked in this list by their impact, we really have a guide for where we need to invest if we want to achieve the best health. Now, this is a policy or a concept, social determinants of health, that's been known for decades, officially titled that since the White House studies, but understood since the days of Virchow and even Hippocrates. But it's been described as existing in something of phantom zone. The other children of the 70s will recognize the Superman 2 reference here, the bad guys off where you can see them, but they're actually not able to have any impact. And that's what social determinants of health has often been described as. But there's been a real change, and this is Sir Michael Marmot, who's been one of the leaders, the author of the Whitehall studies, and he says that I should stop talking about the phantom zone, that it's really a concept that has come out of the margins and started to be mainstream. The CMA, we're hearing more of it from elected officials, and we're starting slowly to see this come out in the public. And some of the evidence of that happening are documents like the physician role in health equity from the CMA, and this best advice document on social determinants of health from the Canadian College of Family Physicians. And really what this is about is how to advocate best for populations and address social determinants of health from the vantage point of a practicing physician or other healthcare provider. And I think that's a very important thing for us to keep in mind, because in the UK, there's a study that showed that 1 in 6 Brits trust their politicians, but 9 in 10 trust their doctors. And similar numbers are here and in the United States. And with that trust comes power and comes an ability to use your voice to achieve something you want. And we can focus that on achieving better salaries for ourselves, or we can focus on achieving better health outcomes for the population, a la Spidey. We had a reference from the Dean, thank you very much, to social accountability and the importance of that, and how this really is at the heart of our profession. This is why we exist as a profession, is to address health. And this concept of social accountability urges us to think more deeply about that and really try to examine the gaps in our service and research and education in terms of how we're addressing priority health needs for our populations. But there are objections to this. Some people would say, that's not really my job, I trained to be in a clinic. But when you look at the CanMed's role, right there, it's health advocate, very prominent, and other of those roles really do apply as well to how we work in partnership, work with communities. It really is at the core of what we try to do, especially if you think that you didn't go into your profession saying, I want to do this procedure or ask this history. You want it to make people better. And when the procedure and the history make people better, great. But if that's not enough, we need to be thinking at different levels. And those levels have been described very well in that CFPC paper, urging us to be better avocados. Avocat in French is avocado and lawyer advocate, so I think that's why they chose the image. I like it a lot. But they talk about the 3 different levels: micro, meso, and macro. So right, that individual patient level, the larger community level, and then society as a whole. A couple of great examples at the micro level. One is out of Toronto, where there's been a group led by Gary Block and others looking at screening for poverty. So asking that question of your patients: do you have enough money to make it through the month? And if you don't, how can we connect you to better resources, and how can we change our approach to your clinical care as well, recognizing that there are different risk levels associated with poverty. We're starting to do something similar in Saskatchewan, expanding it to all of the social determinants of health. So we've designed a iPad-based tool that the patient fills out while waiting to see the provider, and they answer a series of questions on determinants of health, and then it's linked electronically to the 211 database, a searchable database of available social programs, so that in that visit, the clinician goes from, I care about the social determinants of health but don't know what to do about them, to a set of real tools right in front of them to say, this patient would benefit from you calling this number or connecting to this program or filling out this form. The Upstream Doctors is a book out of the States that looks at the meso level, at different clinical groups that are working with, for example, food security, community garden programs in their community, or providing clinical services in a housing co-op, etc. So really looking at the environment in which that clinic exists and what kind of a neighbor is it. And then as we look to the macro level, here's an example of physician advocacy that's been very successful in Canada over the last few years. The response to the cuts to the interim federal health program for refugees, which physicians and other health providers and professional organizations like CMA, Canadian Nurses Association, other really came out strongly against those cuts, which reduced care for all levels of refugee and practically eliminated it for some categories of refugees. And they did pretty impressive things. They got into the streets for days of action that this is advertising, and also went through the courts to fight those cuts. And the result was major regression in those cuts or return of those services. And now we have a commitment from the new government to return them to the previous level. This is also of particular interest to me. I'm from Saskatchewan. 50 years before those cuts, we had protests from doctors against the introduction of Medicare. We had physicians in the streets saying they didn't want universal coverage. Now, we could parse out what they were thinking and why, but the reality is 2 things. One, within 5 years, the vast majority recognized that it actually was a better system to have Medicare available for their patients. And 2, 50 years later, instead we see physicians in the same exact streets, and this was a source of great joy for me to be a part of, 50 years later now advocating for universal care and not leaving any groups marginalized. Now, I'm going to go to one next level of macro, and we're going to try something out here. It's not going to work. Okay. All right. I was going to show you a video, but I'll encourage you to find it. But the video tells a story of kids in the river. So you've got a story that many of you have heard before, but imagine for a moment you're standing at the edge of a river and you see a baby floating by. And brave soul that you are, you dive in and you haul that kid to shore. But then along comes kid number 2. So you got to dive in and save that kid as well. And then kid 3 and 4, there's all kinds of children drowning in the river. So as well as saving some yourself, you're calling all your friends, you're getting everybody involved in trying to save these lives. But eventually, hopefully, somebody will be bright enough to say, wait a minute, who keeps chucking these kids in the river? And they go upstream to try and find out. We do have this animated video that is from thinkupstream.net that shows that in an animated form. But before we had that, I needed to give this talk and talk about it. So I threw my son in the South Saskatchewan River just to really illustrate that. So if you ever ask him who keeps chucking the kids in the river, he's got a very singular answer. Just before you call Child Protective Services, Andrea, you can see me. You can just make me out under the water holding up. I swear. I swear. I'm sure his therapist will find it a very entertaining story someday. So what that refers to, of course, that upstream story, which is, a sticky idea. It's one of those notions that once you start thinking about prevention and health through that mindset, it's hard to forget about it. It's hard to go back to saying healthcare is the most important thing when you realize that that's just fishing kids out of the river and not keeping them from falling in the first place. And upstream is really a movement to try and share this idea of health as our primary goal and the social determinants of health as the roadmap to reach that destination. We're a national nonprofit organization, nonpartisan organization, dedicated to really shifting the frame of Canadian discourse around health and politics as a whole. The way we do that, we've got our three boats there that make up the logo, and those refer to the three parts of the organization. The think tank, where we work with experts and advocates from across the country to identify what are the best policy options available to address the social determinants of health. We then connect with authors and artists and videographers to try and tell those stories in a meaningful way. Because if you don't connect to real lives, then all of the facts in the world are going to make no impact in changing people's opinions on what the best options are. And through those stories and that evidence, we work to build a community of individuals and organizations around the country who are, in their own campaigns, in their own activities, using that social determinants of health and upstream language so that over time, that becomes the mainstream approach to thinking about policy, a longer-term view with a focus on health outcomes. An example of this at work in Saskatchewan, last year we worked with the food bank and the health region to encourage our government, which is one of only two that doesn't have a poverty reduction strategy, to invest in one of those. And the way we did that, we started with the evidence. We crunched the numbers and showed that $3.8 billion is lost each year to the Saskatchewan economy due to poverty. And that's about 2/3 of that due to decreased economic activity, the other third through increased health, social services, justice costs. But then recognizing we needed to connect that evidence to emotion, we worked with people actually living in poverty who are willing to share their stories. Stories like Olivia, whose mother had to quit her job because Olivia needed glasses, which doesn't make a lot of sense, but if she was working at her minimum wage job, she couldn't afford the glasses, but if she was on social assistance, she had benefits to cover it. So that you can see how that's a step backwards for that family and for society as a whole. So telling those stories, we got people together with this poverty cost campaign, write letters, and connect with their MLAs, and the result was that we actually got a commitment from the provincial government, from the premier to have a poverty reduction strategy, and he even invited myself and others involved in poverty costs to help write at the very least the recommendations for that strategy, which is this document, which included a recommendation to drop poverty by 50% within the next 5 years, and looked at, among other things, the idea of basic income. This notion that if we have a floor below which we let no one go, if you file your taxes and you're above a certain level, you pay taxes. If you're below that level, you actually get topped up to the level you need to survive in today's society. That with that, not only could we very obviously drop poverty, as income is the way we measure poverty, we could also give people the opportunity to get beyond the so-called welfare wall, the limitations that are in place for people who are on social assistance that often make it more difficult for them to find work or to thrive in other ways. So these are the kind of ideas that I think connect back to that notion again of health in all policies. And we're really, again, with the new federal government and hopefully some new openness to these sorts of ideas, that's our next phase, is to really try and promote this idea of health in all policies. We're bringing Sir Michael Marmot to Canada in April for a conference to focus on that idea. And we're hopeful that over time, we can continue to shift the discourse towards this idea of health as the most important goal for our society. Now, this work is exciting work. It's wonderful to be able to come and talk to folks like you and to work with luminaries like Drs. Turnbull and Dosani and think about these issues. But there's also some tension there because, well, I'm going to do a half-day clinic this week instead of 2 full days of clinic because I'm off doing these talks. And there's patients that I really want to see and want to see me, and that's what I train to do. And so there's always a bit of a tension there about doing this kind of work. But it only takes going back to clinic for a day and seeing my patients back again with the same things, or somebody else who's come to the clinic with an illness that isn't related to the clinic. It's related to whether they have work or not, whether they have enough money, whether they have access to food. And we just send them back into the same conditions that made them sick in the first place. And until we have social change, we're not going to see the real results that we want out of our clinical responses. But in order to have that social change, we need a frame that allows the space for that social change. With that, I encourage you to check out Upstream Action and join us again this evening for the talk with your mayor and Martin Olshinsky, the law prof from here at U of C, to discuss more ways we can look at health and its intersection with how we make policy and how we think about politics. And that's it for me. Thanks very much for your time.
Thank you so much. I just wanted to let everyone know that we are going to have an opportunity for questions following our speakers. So if you have pressing thoughts and questions that you would like to ask Ryan, please write them down because we will be making time for that. I'm already feeling renewed and refreshed. I think many of us who work in these areas need to come together and hear the hope that is embodied in the new frameworks that are being suggested. The transformation and the social change is really, I believe, happening, and I think there's a feeling of hope across the country and certainly across this medical school that change is possible. So thank you so much, Ryan. I'd like to now ask Simon Colgan to come up and introduce our next speaker, Naheed Dosani.
Good morning, everybody. My name is Simon Colgan. I'm one of the palliative physicians working here in the Calgary zone. I am very happy to be introducing the next speaker. I first became aware of Dr. Dosani when I worked, I was actually researching some palliative programs in Canada, working particularly with marginalized populations. And Dr. Dosani is a palliative care physician working at the Inner City Health Association, or ICHA as he calls it. He's recently completed the conjoint palliative medicine residency program at the University of Toronto, and prior to that, his residency in inner city family medicine, where he served as co-chief resident of St. Michael's Hospital and Family Medicine Residency Program. After completing his training, he founded PEACH. So PEACH is the Palliative Education and Care for the Homeless. This is ICHA's newest program aimed at providing supportive and quality of life treatments for homelessness and vulnerably housed patients in life-limiting illness. You can see why I've written this all down. More recently, Naheed was awarded the 2015 Early Career Development Award by the College of Family Physicians of Canada. As Associate Clinical Professor with McMaster's Faculty of Health Sciences, he teaches healthcare trainees at all levels, serves on the Board of Directors for Agincourt Community Services Association, and on the Steering Committee for Health Providers Against Poverty. Naheed is passionate about social determinants of change, inner city health, global health equity, and social media. You can follow Naheed on Twitter at NaheedD. He put that in. I'm delighted that Dr. Dosani has been able to be part of this CCRED conference today. So without further ado, I'll hand you over to Dr. Dosani.
Wow, what a privilege to be here today. Before going further, I just wish to acknowledge the ancestral, traditional, and unceded Aboriginal territories of the Tsuut'ina Sarsi, the Niitsitapi, or Blackfoot, Nakota Stoney, and peoples on whose territory we work, live, and play, and on whose territory we stand right now. So Mariko, do I just hold this down? Transitioning to the wireless mic. Okay. All right. So, real pleasure to be here today. Thank you. Good idea. An honor to be speaking to you, to join Dr. Turnbull, Dr. Meili, who have really laid the groundwork for a lot of the discussions that we're having around addressing the life-limiting illnesses and the quality of life needs of individuals who are marginalized, homeless, and vulnerably housed. I do not have any disclosures of interest, conflicts of interest to disclose. I'm really not that important. Today, we hope to detail some of the unique issues and challenges faced by vulnerable populations as they start their end-of-life journey, and Imagineer, come up with some unique ways we might be able to address these challenges together, and then we'll follow through in the workshop sessions as well. So I'd like to give some props and respect to the organizations that have made the work that we do possible in the streets of Toronto: Inner City Health Associates, otherwise known as ICHA, St. Michael's Hospital, and Toronto Central CCAC, which is our local home care organization. Closer or further? Louder. Softer. Okay, got it. Let me know. Turn me up or turn me down. Okay, so can anybody tell me what palliative care means? Walk across. Any thoughts on what palliative care means? The Latin definition of palliative care. If you translated it in English, what does it mean? Any thoughts? Anybody? Sorry? To fail? Comfort. Usually someone says end-of-life care, and that's actually not true. So actually you're onto something. The Latin translation of palliative care is to cloak, to comfort. And so when I think about cloaks, I'm really into fashion, right? So I think about female cloaks, really great fashion sense. This is the kind of cloak that I wear when I'm out, doing palliative care. On my really, really exciting days where I'm pumped, this is actually the cloak that I wear. But in all reality, I really became exposed to the concept of palliative care when I came across this quote that I found outside the palliative care offices at Sunnybrook Health Sciences in Toronto, Ontario. To cure sometimes, to relieve often, and to comfort always. A 15th century definition of medicine. And it's funny that in the 15th century, the definition of medicine was to comfort. And we have actually come so far that we're really good at curing, but now there's a lot of conversation about how we comfort. And so it got me thinking a little bit about what actually makes Canadians sick. And Ryan, you totally stole my thunder with this, so I'm just going to get to it. You stole the infographic. We all use this infographic because it's just so cool. But we all are, Ryan's given us a great introduction to the fact that what makes Canadians sick is not necessarily the medical or biological diseases that are present within our body. And as a resident trainee at St. Michael's Hospital, going through my residency, I became aware of this very quickly. You see, we work in inner city blocks. And we work in rotations where we work in the shelter system in Toronto. Does anybody know this building? Anybody from Toronto know this building? Yeah, what's this building? Seton House. I know you. One of my teachers from residency. Oh my gosh. So that's great. Didn't expect to see you here. So Seton House is a 530 bed men's shelter with over 15 programs within it. And as part of our rotations at St. Michael's, we work in the infirmary and the managed alcohol program. And it was there where I started to recognize that what makes Canadians sick is not necessarily biology or medical disease, but the social determinants of health. It came through when I met a gentleman named Terry. Terry was a 38-year-old gentleman with a head and neck cancer. He had frequented many ERs, went ER to ER, hospital to hospital, walking clinic to walk-in clinic, seeking pain control. The kind of pain control you and I would so easily get for his invasive head and neck cancer, which really, really hurt. When I admitted him to the infirmary, he was in pain crisis. He was rocking, shaking, and of course, he didn't trust the healthcare team at all. It took several days to really develop a rapport with Terry. And eventually, he did agree to join me in a pain plan. And I remember going home one night, being really excited about the concept that he's going to be participating in this pain plan. I got to the shelter the next day, and I couldn't find him in his room. I couldn't find him in the cafeteria. And I asked his roommate, "Where's Terry? Where is he?" And he said, "You didn't hear, Doc? Terry died last night." I said, "What?" He's like, "I don't know. He came into the room screaming. He had a pain crisis. He said, 'Nobody cares about me. Nobody cares about my life.' And he died on the street in a combination of alcohol, opioids, and benzodiazepines." And so for me, yes, a sample size of one, but a narrative that is so true and so real became very real to me. And then I met a patient named Mary at this building, which is women's residence in Toronto. You see, Mary was a 66-year-old lady who had liver cirrhosis, a history of mental illness, and some drug use. She was admitted to the hospital with a pneumonia, a really bad pneumonia. I actually never really got to talk to her, frankly. She wasn't able to communicate with us because she was so sick. The team started talking about admitting her to the ICU and intubation and putting her on ventilators. And then in the notes, I saw this phone number for the street nurse that had been caring for her for over 18 years. I called the street nurse and said, "What would Mary have wanted? Did you guys ever talk about this?" And of course, the street nurse said Mary would have never wanted to be in an ICU, she would have never wanted to be intubated, and she would have wanted a quality of life, end-of-life journey. She was admitted to hospice and died peacefully among friends, receiving the kind of care that she wanted. So I ask you, what story is more common in the streets of Toronto? The story of Terry or the story of Mary? Terry, more common? Totally more common. Quick snapshot of the situation when it comes to homeless populations in the city of Toronto. On any given night, there are 5,200 unique individuals who are homeless in our streets. 450 actually living in the streets. It's a very sick population. 3/4 of this population has chronic disease, Hep C rates that are 28 times higher than the Canadian baseline, heart disease rates that are 5 times higher, cancer rates that are 4 times higher. 1/3 of this population suffers from severe mental illness, and the fastest growing subset of the homeless population in any city in North America or Europe is the elderly. These are individuals who are over the age of 55 and are new to homelessness. But what happened in 2010 was we got the results of the HIT study, the Health and Housing and Transition Study, out of the Center for Research in Inner City Health. This study showcased the fact that we were just looking at the tip of the iceberg. It showed that for every one person you see that is actually living in the streets, there are actually 23 other people living in the city, the hidden homeless, the couch surfers, people who are transiently moving in and out of housing conditions that are very poor, who are actually vulnerably housed. And so how do we define that? People who spend more than 50% of their income on rent, people who live in poor conditions, people who couch surf, people who have unstable housing. And why do we care? Because the health status of that one person living at Yonge and Dundas on the street in Toronto is just as bad as the 23 people we don't actually visually see. So when we're talking about the homeless, that's just the tip of the iceberg, because you're talking about a whole population out there in the city that you don't see that suffers and has their health fail or has ailments of the social determinants of health. Needless to say, you wouldn't approach obesity with a homogeneous answer. This is a heterogeneous population. They're not all the same. We kind of just box the homeless together. No way. Very complicated population. Some would be surprised to find that 1/3 of our homeless population actually has no mental health or substance use issues. Often the sequence of a poor sequence of events, sometimes some bad luck, and a decreasing social safety net that we're seeing provincially and federally. 36 articles in the literature. After Terry died, I went to PubMed, I went to the librarian and said, how many articles are there out there that have talked about the intersection of palliative care and homelessness? 36. What topic in medicine has only 36 articles in it? I was shocked and stunned. Most were articles talking about people saying we should do more. I was so grateful to find Dr. Turnbull's piece in 2006 talking about their amazing work in Ottawa with their inner city hospice. But outside of that, there was a lot of discourse and not a lot of action. Terry's death made it very real that there needed to be more action. But from that literature, I found some really interesting data. The average life expectancy of a homeless person living in the streets of any metropolitan area in North America or Europe is 34 to 47 years old. I'll say that again, 34 to 47 years old. what is the average life expectancy nowadays for a housed Canadian? Any thoughts? 81.5, says Dr. Turnbull. So I work with colleagues who work with Médecins Sans Frontières and say, when we look at this public health profile, this data that you're working with, this population's health is actually worse than many of the low and middle income countries that we're working in. Here's the catch. These people are in our backyard. They're 2.3 to 4 times more likely to die as compared to us. And where are they dying? 34 to 60% of the time, they are dying in acute care hospitals. What percent of Canadians want to die at home? Any thoughts? 70? Any other thoughts? 80? 90. 90% of Canadians, when surveyed, want to die at home. This population is actually not that much different when you really think about it. The thing is, what home is and what that means is a lot different. And then this happened, and this just blew my mind. The province of British Columbia did a full chart review. They took all the deaths of homeless individuals in that province for that year and did a full analysis of the data. And what they found was that homelessness cuts your lifespan by half. Not having a roof over your head cuts your lifespan by half. Can anybody name a disease that predictably cuts your life expectancy by half? There's disease out there. I mean, we all have cared for and know individuals who suffered a life-limiting illness at a young age. We've had cases like that. There are genetic disorders. But predictably, a disease that cuts a person's lifespan by half. So it got me thinking, should homelessness itself be considered a palliative diagnosis? Is it not a terminal diagnosis of the social determinants of health? If we really think about what Ryan was talking about this morning, if this social determinants really make us sick, homelessness itself could be considered a terminal diagnosis like end-stage cancer, like stage 3, stage 4 heart failure, or even like late-stage COPD. So a few colleagues got together and started thinking about an intervention in the streets of Toronto called PEACH, Palliative Education and Care for the Homeless, aiming to meet patients where they're at in 2 ways. Number 1, geographically, wherever they're at in the city. Could be under a bridge, on a street, in a shelter system, in the hospital, in a clinic, or wherever they're at along their disease trajectory, early on in the disease, in the middle, or late. What we're trying to do is bring the latest and greatest evidence of 2 worlds together: homeless health delivery, harm reduction, sensitivity to mental illness, and outreach. Number 2, we're talking about palliative care, early palliative care. For those who may have heard about this, I don't know, may not, there are 4 randomized control trials now showing the benefits of early palliative care. So someone's diagnosed, and they meet a specialty palliative care team or a primary care palliative care team right away. The studies have shown that people feel better, they mentally feel better, they function better. But 2 of these randomized control trials actually showed that you live longer if you get early palliative care. But these studies were done in ivory tower settings. One has to wonder if they're actually applied to marginalized or vulnerable populations. So we're a mobile service. I kid you not. It's myself, our nurse Nameric, and my Honda Civic. And we just go around the city and we just see people. We're street and shelter based, so we meet people where they are at. There are no-go zones. We meet people where they're at, providing supportive quality of life and early palliative care treatments. And in some cases, we offer healthcare navigation for folks who are undergoing investigations and treatments, because we all know that it takes a lot of health literacy to manage to get to your tertiary oncology, radiation assessment, and then treatment. It gets really, really hard. So we offer those services as well. I'm really grateful to have the opportunity to present some highlights of our 1-year findings. Very quickly, we just got this data, so we still have some more work to do. But we just wrapped up our first year, and we're really excited about it. In our first year, we saw 47 folks, 37 males, 10 females. We had a target of seeing 1 new consultation a week. We saw 47, not 52. The actual art of putting together a consultation is really, really difficult to get the patient there, caseworker there, the social worker there. It's a lot of things to align. But we had some success. The average age of our patients was 57. When it came to where these patients were coming from, 28% of our patients came from the managed alcohol program at Seton House, 31% in total at Seton House. We had 11% from another transitional housing complex in the city, 8.5% from women's residents, and approximately 50% of our patients were vulnerably housed. Rooming houses, boarding houses, Toronto community housing, living below the poverty line, in and out of different types of housing. And these were actually the patients that we saw. A third of our patients had cancer, 40% had end-stage liver disease. We saw a lot of other diseases as well. But yeah, so a little bit of an array. This is a pictorial showing that. At the 1-year mark, we had a caseload of 20. We found that we've always been carrying 18 to 25 patients at any time. We actually supported 26 folks to end of life. 62% of our patients had no ER visits. 64 had no unplanned hospitalizations. There is no data set to compare to. I cannot tell you that that's better than anything. There is no comparator to that. There's no control. You can appreciate it's really hard to control for that, but that's what we found. We found 75% of the time we were actually working with other providers in the city. This is truly a community working within communities. And so that was really something we were proud of. Where it was possible, we offered harm reduction, and it was 67% of the time. 85% of the time, patients wanted to be connected to loved ones that they had not talked to for years, and we were able to do it. We would go on Facebook, LinkedIn, we would text people, we would call people to connect them to people they hadn't talked to for 15 to 20 years. And 98% of the time, we were able to offer another psychosocial support, be it a Hospice Toronto volunteer, be it an Aboriginal elder, a priest, and a mom to our patients to provide psychosocial supports, in addition to the Honda Civic, the doctor, and the nurse, and home care. Interestingly, building community, we got a lot of text messages, emails, phone calls by providers in the city, nurses, doctors who wanted to know more, wanted to talk about what we were doing. We actually developed a workshop that we're actually going to present today and work with you guys this afternoon, and have presented at various conferences and educational opportunities across the country, actually, have had some media exposure, and actually were able to convert 3 mainstream palliative care services to say, yes, we offer alcohol harm reduction in the end-of-life trajectory officially. They will actually say it out loud. And so we were able to do that in our first year. We have a lot of work to do, but we're really grateful that that was able to happen. Education is so key. So we actually had 20 trainee rotations, so medical students, social work students, nursing students, residents join us. One thing that we really found was really difficult is, while we know that 90% of Canadians want to die at home, we find that the homeless population is not that different. Only one of the 8 shelters we actually work in allowed a shelter death. There is still a lot of stigma. There's still a lot of taboos about dying in a shelter, and that has to do with the fact that social service providers really get zero training about death and dying. Meanwhile, there's 3 to 5 deaths at Seton House a month. I mean, it's pretty public knowledge, and there's very little training about that. We've had discussions at City Hall about this. There are ongoing discussions about potentially a development of some infrastructure to support folks at end of life. I've been talking to Wendy Muckle in Ottawa, which has been great. Interestingly, and it's a really timely thing, in Ontario, there was a scathing report about inequality in palliative care put out by the Auditor General in Ontario. So you know I jumped on that, right? So we got these invites to all these tables, and folks were talking about on-call stipends for palliative care doctors and on-call structures, and I'm talking about supervised injection sites and harm reduction, and all the other palliative docs were looking at me like, what is this guy doing? But really advocating for our population. And then federally, Bill M456, which is a pan-Canadian equitable approach to palliative care. So all Canadians have access to equitable quality of life treatments as they approach end of life. And we were very privileged to have the opportunity to write the marginalized population section in that bill. Okay, some things that are really hard: advanced care planning. Talking about death for a population that often is living at the edge of death a lot of the time is a very scary thing. In palliative care, we love things to be kind of boxed and very metric. We love our ESAS scores, and we like to track scores over time. This population doesn't have time to fill out your questionnaires. They don't have the patience. This is relationship-centered care. So doing the pain and symptom management was really hard. And some of the things that we do really pragmatically to protect patients and sometimes ourselves around addictions, like opioid contracts, get really hard to talk about when someone is approaching end of life. And so, yeah, we did opioid contracts, but only 36% of the time. It's a really hard thing to actually do. So definitely some real challenges. I'm looking at Mariko, wondering how much time we might have. Oh, perfect. So luckily for me, there were 36 articles out there when I went to go look at the literature. And thanks to folks like Dr. Turnbull in Ottawa, thanks to folks like Ryan McNeil in Vancouver, and John Song in Minnesota, Dr. Huang in Toronto, there actually is enough body of evidence to actually put some best practices together so we can think about ways to better deliver palliative care services to structurally vulnerable, but particularly homeless and vulnerably housed populations. And so a few amazing folks at the Good Neighbors Club and I came together to put these 7 best recommendations together, and I'd love to work through this with you. We'll be expanding on these best practices in the workshops in the afternoon. Number 1, maintain flexible eligibility and admission criteria. Let's face it, mainstream palliative care facilities across the country tend to favor folks who have normative behavior. My favorite phone call I got when we launched the Peach program was we had admitted a patient to a palliative care unit and or hospice facility that I won't name. The director called me in a hissy fit. She was so mad. She called me and she said, your patient was admitted, he has end-stage cancer, and he gets up every single day and leaves, and he's not receiving our pain and symptom management and quality of life treatments. If he doesn't stay here, I'm gonna discharge him. And I'm like, first of all, I really appreciate your passion for what you do. Like, this is amazing. We need more people like you. Second of all, let me give you some background, ma'am, on the situation with this patient. He lived 15 years on the street in an emergency shelter where the routine was getting up and getting the heck out of where he was staying, living a nomadic life where he had to do what he had to do to survive, panhandle, work odd jobs, whatever he had to do. That process is not going to change now that he's receiving your quality of life treatments in this facility. In fact, palliative care is all about the cloak, comforting, quality of life. And quality of life means different things to different people. For him, the best quality of life treatment he could get at this very moment is the social determinants of health. Stable housing, some support, some food and water, someone to ask him how he feels at the end of the day. So you are doing an excellent job, and I really appreciate, what you're doing. She took it with a grain of salt. We're friends now. But this is the kind of thing and the kind of culture we have in hospice and palliative care, and it's documented in the literature, that really makes it hard for us to admit patients with addictions, mental illness, and housing issues to mainstream palliative care services. There's a lot of assumptions in home care. In Toronto and Ontario, there's an assumption that we're going to give you this many hours of home care, and then, your family will supplement the rest. What family? What supports? These are folks who are socially, psychosocially isolated. They don't have that, and we can't make that assumption. Well, some facilities actually are anti-drug, which harm reduction is a really big deal. We're going to be talking about it all day. Clearly makes it very difficult to care for this population. Some facilities even have codes of conduct, which make it very hard for us to support patients with mental illness. So we really need to think about criteria for admission to palliative care, but make that criteria low threshold. I think we're going to study this at some point, but we kind of have an internal rule within the Peach program. We do a prognostication using the tools we usually use in palliative care, and we pretend the person was like a housed Canadian, and we make that assessment. We think this person will live 3 months. And then you know what we do in the Peach program? Divide by 2. We're usually right. Homelessness actually usually cuts that life expectancy by half. So this whole less than 3 months thing, which is the provincially funded criteria to admitting people to palliative care, at least in Ontario, it's garbage because it does not take into account the social determinants of health and what's actually killing people, lack of housing and lack of supports. Number 2, once people are in programs, we need to offer continuous case management. You know what? It's really interesting because one of the best practices in palliative care is actually continuous case management. Guess what? One of the best practices in homeless health delivery or social delivery is actually the same thing, continuous case management. These systems rarely talk to each other. Spend a lot of time hanging out with folks who are mental health caseworkers, social workers, who work for different organizations, and they are actually told that once a patient has a life-limiting illness and is palliative, they're supposed to discharge them. As if there's this other system that totally takes it up. Doesn't happen. These are people who are falling through the cracks. Now, a lot of these folks just keep these patients on their caseload. They don't stop. But they're actually told to do that. We need a system that integrates and talks to each other. We need that continuous case management from admission all the way to end of life. Number 3, we need to be flexible in our program policies. Whether you're running a mobile palliative program, whether you're running a palliative facility, a hospice, whether you're in hospital, we need to think about harm reduction. Honestly, abstinence-based approaches are not going to work for this population. And there are facilities that actually will not accept referrals from patients who have addictions. On the palliative medicine side, I have to be honest, I got 0 hours of harm reduction training in my palliative medicine residency. I don't blame colleagues who feel uncomfortable with what they're dealing with. It's complicated, it's difficult, and sometimes it's very, very scary, not to mention controversial. But let's be real. If we actually are punitive in how we approach addictions and we shame our patients, not only will we not be able to build bridges for that with them, our pain and symptom assessments are going to be totally inaccurate. They're going to be lying to us. They're going to be trying to do what they have to do to get through or get by. And we won't get the referrals. What Ryan McNeil has said out in Vancouver, and I think what the Ottawa group has shown, is that when you embrace harm reduction as a palliative care program or palliative care facility, you actually get to see more people with serious life-limiting illnesses. Number 4, foster peer support networks. Interestingly, there's no literature on this in homelessness and palliative care, but a lot of literature around this when it comes to homelessness itself. It's the thought that with a peer leader, with a peer mentor, my experience may actually be better as I approach end of life. There is a documentary, I think it's called Serving Life, that tells a story about a palliative care unit in a prison where they actually have prisoners care for patients as they're approaching end of life in a palliative care unit. We're talking about that kind of thing. And when you really think about it, it really does make sense. This is the story of Dan Thibodeau, who is a 52-year-old gentleman who had end-stage metastatic lung cancer when he was referred to us. As a trainee at St. Michael's Hospital, you knew Dan, and I can talk about Dan because he was in this press piece. You knew Dan because he was really famous in the street. Like the Toronto 52 Division, the police, like they visited him when he was sick, not to like arrest him because they liked him and they wanted to like hang out with him. And so when I saw his name, I'm like, oh, Dan, that's really cool. But Dan had worked 15 years to battle addictions and various issues to get this apartment that we're sitting in here, which was at the Fred Victor Transitional Housing Complex. When he met me, he's like, I don't care what you do, Doc. I'm not moving from here. I will die here. Make that happen. And that was this dignity piece really speaking. What happened though over time is he couldn't care for himself. He couldn't dress himself. He couldn't shower. It got to the point where he couldn't go to the pharmacy to get his medications. Down the hall was a 28-year-old gentleman named JD, and I can talk about JD because I have the permission to talk about him. I don't know much about JD. He wasn't my patient, but JD was a guy who was admitted to Fred Victor with some addictions issues. He had a son. He was really trying to get back into his life, get a job, and get housing, get reacquainted with his family. As Dan started to deteriorate, JD stepped up and said, I want to care for Dan. I'm like, JD, are you serious? You want to do this? That's like dressing him and taking him in the bathroom. JD said, yes, I want to do this. JD dressed him. JD took him to shower. JD went to the pharmacy. When Dan had pain crises or was using more than 3 breakthroughs a day, he would religiously call us and be on point. And interestingly, when Dan did pass away, JD approached us at the memorial and said, Naheed Dosani, who's our nurse with the Peach program, he said, caring for Dan has given me a sense of worth and purpose that I have not felt in years. JD now has a home, living in supportive housing in Etobicoke. He has a job. He's reacquainted with his son, and I'm not trying to say it's all because of this. But maybe there's a rehabilitative component to getting our peer leaders to actually be involved in the care that we provide. I'm just going to read you a letter that JD wrote to his daughter, who actually we reacquainted via Facebook, and they actually had some Skype dates as a result. Dearest Allison, where should I begin? I'm sorry that it's taken so long to write this letter, but I can't physically write myself, and getting it together is not easy. My current state of health not only limits my ability to write, but I'm also heavily medicated, which makes it difficult to form my thoughts. Thanks so much for sending my nurse the photos, having them all framed up and all over my room. My favorite photo and the first one framed is of your beautiful son, Grayson. I'm told my face lights up when I look at it, and Jamie Lee's kids are also so precious. I wish it didn't take such a drastic turn in my life to make contact with you, and for this, I'm sorry. Please know that over the last 20 years, I've always had you in my thoughts, but because of my negative lifestyle choices, I didn't want to contact you because I wanted to keep that as far from you guys as possible. If I was living a life that was positive and not full of addiction, I would not have lost contact the way I did. I love and miss you dearly and long to hear the word daddy from your mouth. My neighbor, primary caregiver JD, and I were making plans to come and visit you guys and the family in New Brunswick, but I also recently was diagnosed with some blood clots that need to be treated with an injection daily. My doctor advises me that it would not be a good idea to be away from my palliative care team in case something happens. My current level of contact with doctors and nurses is extensive, and they are also worried that if I were to travel, something may go wrong, and I would not be able to get the care I need. Again, I love you, I miss you, and I will be writing more in the near future. Dan didn't actually write this letter. This was written by JD. Dan couldn't coordinate due to the brain metastasis that had affected his neurological function, and this was the last letter that Dan would actually voice to his children. Number 5, employing holistic care models. It goes without saying that spirituality is important to all Canadians in some way, as they approach end of life. Not necessarily religion, but spirituality. And what the literature shows is that as people who are homeless and vulnerably housed approach end of life, spirituality becomes more important. Perhaps it's a way of not being alone in a place where being socially isolated is the norm, but now you have a life-limiting illness on top of that. But to be frank, the literature does show that spirituality is a way to cope with being alone, with having loss, and dealing with addictions. So spirituality is really something that we need to think about as well. Number 6, prioritize client dignity. With the fastest growing subset of the homeless population being in North America and Europe being our elderly, dignity, self-worth, and morale is so key. I was doing a tour of the Good Neighbors Club when I started the program, and I was in the alleyway and I saw a camera, and I was told David Bruce, the executive director, it's so great that you have cameras to provide security for your staff. And he's like, that's not for the staff. We're a drop-in men's shelter for men over 50 who are typically new to homelessness. And that camera is actually because our guys don't know the ways of the street. They're getting mugged, they're getting assaulted, a lot of them are really sick, and they're getting picked on. And that's actually what that camera is for. It really brings this issue to light. Medical people don't look at things the way we're looking at them. This is how the literature kind of articulates how this population feels about the medical community and what we can do to do better. Isn't it funny that every hospital slogan is patient-centered care now? I think that's like really hilarious. But forget patient-centered care. This is relationship-centered care. They don't care as much, I'm painting with a broad stroke, they don't care as much about your complex methadone or neuropathic treatments or the number needed to treat. They're typically not the point. Will you be there for me? Will you be there next week? Will you be there the week after? When nobody is there and I'm in a hospice dying, will you be there then? Relationship-centered care. So it's the stories of the story of Archie, who was a 66-year-old gentleman who was an engineer, worked for Bombardier, and was actually new to homelessness at that age. He was a patient that we actually supported towards end of life. And dignity was really key for him. Unfortunately, like the story I told at Good Neighbors Club, he was actually a victim of assault, quite frankly, and frequently in the shelter system, and supporting him on his end of life journey. Number 7 is an important one because a lot of the folks we see have this long journey, 10, 15 years where they're searching out housing. And why on their end-of-life journey would you ever stop that process? Dan said, I had worked 15 years to get this apartment. And before I die, I want to get this housing, and I want to die in this housing. This is a dignity piece as well. So a lot of folks are searching for supportive housing first. Let's meet them where they're at and make that possible. Overall, we've learned that it's possible. Sometimes you got to customize care plans and it takes more time. But let's break down silos and think about things a little bit differently. It's communities working within communities. It's building capacity, which is really the theme of today. And it's relationship-centered care. And it really begs the question of what a human life is worth. What's your life worth? What's your life worth? What's your life worth? Is it worth the same worth as my life? And really, do we want to live in a Canada, in a country, or a world, where every single person has equitable access to a good death, a good life, a good end of life, a good trajectory towards end of life? It's dignity, it's human rights, and it's social justice. We're trying to get people to change the way they're thinking. Not why is this part of the iceberg above the water, which looks at the individual risk factors. Oh, he was lazy, he was a bum, he smoked, that's why he got lung cancer. No, we're trying to get people to see what's below the tip of the iceberg. Why is the water so salty, causing the iceberg to float so high in the water? These are the social factors at play, the social determinants of health that lead to disease and ailments. And really, it's a process of change. And asking ourselves as a community, what kind of change do we want? Living in the hospice and palliative care world, it's really interesting because palliative care is actually a change movement for the people, by the people. It's actually a bunch of people in England, the United States, and Canada who told all these doctors and nurses in the 50s and 60s, you guys are crazy giving us this chemotherapy, we have pain, our quality of life sucks, and you don't care about our quality of life. And then Cicely Saunders in the UK started the hospice movement. Balfour Mount in Canada, in Montreal, started palliative care in Canada, and all of a sudden it became a thing. Palliative care is a social justice movement in and of itself. We've come so far that we now have an opportunity to actually come full circle and make social change, building capacity, and a community of care that really cares for all Canadians and makes that possible. In conclusion, to kind of piggyback on what Ryan has talked about, the social determinants do impact our health, but they also impact our end-of-life journeys as well. And clearly, Canadians in general have issues accessing palliative care, but those who live in low social economic status settings, who are homeless, vulnerably housed, have additional barriers that make accessing palliative care even harder. And finally, and I think that's what the theme of today is about. There are innovative solutions out there. We can imagineer a world where there are no silos, where there are no barriers, and it's possible for us to make system change, to make access and quality of care possible. So thank you so much for having me. I really appreciate it, and I hope to see you guys in the workshops this afternoon.
This is such a great event because we're talking about issues that are so relevant here in the city of Calgary. And, it was back in May of 2014 that myself and the Executive Director of the Calgary Drop-In Centre, Debbie Newman, went on a trip to Ottawa to see Dr. Jeffrey Turnbull. And, when we came back, from that sort of transformational experience, the question that we started to ask ourselves, and I know many of the other great shelters in Calgary, like the Alpha House and the Seed and the YWCA for Women and others, the question was, how can we do better, for the 600 to 900 chronically homeless Calgarians? And these folks are, as we know, the point in time count told us that we have about 3,500 Calgary homeless folks, but of that number, probably 600 to 900 of these have been homeless for over a year. I mean, we have over 500 of them in our building alone at the drop-in center. And as you know, with this particular population, they have significant mental health and addiction issues. And the physical challenges that they have far exceed what you or I would have. And at least in the drop-in center, over 60% of these folks are over the age of 46. And so as we can tell, their outcomes won't necessarily get any better without some help. So, several of us agencies began to put together a task force, and we're so grateful that some pretty high-level people in Alberta Health Services, along with Human Services, the Calgary Homeless Foundation, Calgary Police Service, Source, the Mustard Seed, the Alex Cups. I mean, I could go on and on. We've been meeting together thinking about how we could address this challenge more meaningfully. And, we had booked Dr. Turnbull to come actually and consult with us tomorrow, which he's going to be doing at 8 a.m. And so when we had that knowledge in hand, actually I approached Dr. Van Nguyen from CUPS, probably 6 or 9 months ago, and we started talking about, well, we've got this amazing guy coming to Calgary. How could we leverage him, not just for the task force, but also for the community? And, one of the things that is so impressive to me when you think about a guy like Dr. Jeff Turnbull, and I don't really know him very well, but had a couple of privileged opportunities, is, I watched him work with homeless populations in shelter and in supportive housing in Ottawa. And I was blown away by the compassion, by the humility, by the ability to connect. And when you think about a man who, you read off his biography, it's like, I don't know, there should be a Hall of Fame, right, with his picture there. You think about receiving the Order of Canada, you think about the president of the Canadian Medical Association, and of course the chief of staff at the Ottawa Hospital. And all of these are very impressive, but as a non-medical person, they mean nothing to me if when you engage one of our clients, you don't do so in a way that's compassionate and humble and genuinely caring. And so, you know, I'm so honored to be able to introduce you, Dr. Turnbull, and I wonder if you could all just give him a wonderful round of applause.
Thank you very, very much, Abe. That's very, very kind of you. Not true, but very kind of you. And I see some friends around who actually know the truth about me, that so whatever you do, don't talk to those guys. But what I wanted to really say at the beginning, and just as a prelude, as I look around this audience, and when I think of some of the lessons I've learned over the years, and when I've heard the two earlier speakers, which I thought were fantastic, one, I'll never dress that well, and I was exhausted after both of them, and I thought, my God, how will we ever live up to this level of achievement? One of the things I remember when I was president of the CMA and I was raging on about politicians not demonstrating leadership, I was taken aside by a minister of health who said, you don't get it, do you? And I said, yeah, what is it that I don't get? And he said, well, you know, that's just not how it works. How it works is you develop guiding coalitions. You get the grassroots. You get everybody on side. You create a politically safe zone, and we will follow. And when we do something, then you'll support what we do. But we will not lead. And so what I learned from that was everybody in this room is empowered to make this change. This is the group of people in this atrium who will actually affect the well-being of those people most vulnerable around us. It's not politicians. Don't wait for that to happen. Make it happen on your own, because you have the power and it will happen. Secondly, this is not about, we had two brilliant physicians and one less so. This is about teams. And I see police, I see paramedics, I see social workers and providers within the shelters and the other shelter staffs. This is about a functional team pulling together to make a difference. And everybody has an equal role in this, and everyone has that equal responsibility that Ryan spoke of. It's our job. We must do this. So that's why I'm going to come back to that right at the end, but I thought it was a worthwhile thing right at the beginning to highlight that. So what I wanted to do is, one, say, unfortunately, I don't have any financial disclosures, but I wanted to begin at a very high level and just talk about health equity. Now, we've gone earlier today, we've talked about high-level social determinants of health, and we've talked about innovative programs in providing services for those homeless people who, in the end of their lives. But I wanted to get into the middle ground there and talk about the issue of health equity. And this is something that is a part of my life. I'm the Chief of Clinical Quality for Health Quality Ontario. The quality movement started around patient safety. They've moved into efficiency and effectiveness, and they're thinking about patient experience, all of those things. But always on every one of those lists is health equity. And also on every one of those lists, the one thing they don't do is health equity. So I thought I'd put this in context and talk about equity and the challenge that faces us as all people who work within these environments, not healthcare providers, because it impacts the judicial system, it impacts our health system, it impacts our financial system. So it's as much a Treasury Board problem as it is a health services delivery model problem. So I'm going to begin first with that, and then I'm going to move from there to talk about inner city health in Ottawa as one strategy, one that you probably will not accept, and I wouldn't want you to, but as an idea to build and fit within your own circumstances. So what are some of the definitions, what we're talking about health equity? And this is the one I like that we're using now at Health Quality Ontario. Health equity is achieved when all Ontarians are able to reach their full health potential and receive high-quality care that's fair and appropriate to them and their needs, regardless of who they are, what they have, and where they live. If we could achieve that, then I think truly we would be proud of the systems around us that would serve all of us in our community. There's confusion about what is health inequality and what is health equity. So health inequality is different. So health inequality is when there are differences in health experience or outcomes between different populations. A population who smokes and a population who doesn't smoke. Those people who smoke are going to have a higher incidence of lung cancer. That's an inequality. It's an understood, accountable thing that you have one variable causes another. That's an inequality. But we're talking about inequity here, and that's below. Health inequity, when you attribute these differences to systematic disadvantages that are potentially remediable and considered to be unfair or unequal. The highest incidence of lung cancer on the planet, our Inuit population in Canada. That is unfair, that is unequal. And so that is an inequality that we need and we have the responsibility to address. So what are some of these things? How do we look at inequity? And then I'm going to get down to inner city, because inner city is a strategy, just one strategy to address these. So for those of you probably have trouble seeing that, I'll try and read it out for you as best I'm having trouble too with fairly oblique vision, but inequity in access, the right care, right place, right time. And all of you, I think, would recognize that if you're in a rural and remote setting, or if you're in a homeless shelter in an urban setting, you don't have the same equity as if you were wealthy, access to services, if you're wealthy in a downtown Toronto or Calgary. Care that has to be available, accessible, and acceptable. So Ottawa's got the highest concentration of psychiatrists per capita in the country. We probably need it. However, do you think that I could get a psychiatrist to come down and visit on a regular basis in the shelter when 20% of my people have schizophrenia? When I look at it, major affective disorder, about 80%. Probably the highest incidence of mental health and addiction anywhere in the city. So we have a challenge that getting even that care, even though it's available, it's not coming to my homeless guys. And if we do provide it, it's got to be acceptable to those individuals. And it's got to be accessible. So one of the things, for example, my colleagues say, oh, you've got to come up to the hospital, come at 9 in the morning, I'll see you in clinic. Well, that just is never going to happen. Not for one of my addicted individuals who, at that point in time, are trying to deal with their mental health challenges and their addiction. Don't even waste your time. And when they don't show up, they say, didn't show up, don't ever come back and see me again. And I'd like to think that that was a rare phenomenon, but it happens to me just pretty well daily. And I'm the chief of staff of that hospital. So it's a challenge. Do you think one of my guys, now here I say guys means guys and girls, homeless folks, will ever get on a list to get a total knee joint replacement? Nope, ain't gonna happen. Not today, not tomorrow, hopefully sometime, but that access that we might complain about, getting reasonable access to services, just is not available to this population. And I'm going to show you in a moment how that plays out in the impact that they have on our healthcare system, plus our judicial and also our financial systems. So do they have the same patient experience? Do they have the same outcomes? If you have a stroke in a shelter versus a stroke if you're wealthy, if you have a stroke in a shelter, you're going to have a terrible outcome. And what I would love, what the legacy that I would like to leave for my children would be that equity and health, so no matter what child born at any time in Canada, no matter where they live, what postal code they are, what they have, will have the same opportunity for health. Wouldn't that be wonderful? We are so far from that now. We've got a long way to go. So let's try and work on the first bit, access. So what does that do? And we've heard about that, and I'm not going to talk about it very much more, but just to say that the consequences of inequity are so profound in Canada that I work in Bangladesh, I work in Africa. The incidence of HIV in my injection drug users is higher in the shelters than it is in sub-Saharan Africa, the epicenter of HIV. Hepatitis C is 80% in my injection drug users. Incidence of tuberculosis on a Canadian reserve, higher than where I work in rural Bangladesh. Probably the highest incidence of tuberculosis around people would refer to as Bangladesh, but we have higher rates. I told you about smoking and lung cancer, highest in the planet. If you go from the richest part of Hamilton to the poorest part of Hamilton, life expectancy drops from that 81.5 years by 21 years. Just think how happy we would be if we had an intervention that actually got the population, or even a section of the population, to live by 3, 5, 10 months, not years. We were delighted when our life expectancy went from 81.1 to 81.5 in Ontario. That was a major accomplishment. Well, 21-year difference just by driving down to the poorest part of Hamilton. We know from the Toronto experience, in my shelters, that you're not going to get to the likelihood you'll get to the age of 75 is only 25%. So huge, dramatic differences. So all of us who are responsible and play a role in the shelter environment oversee circumstances that are worse than the developing world. Yet because we publish averages, average life expectancy, 81.5, pretty good. We absolutely neglect massive differences in health outcomes comparable to that of the developing world, as we heard from Naheed. And that's bad. I would argue that that would be really difficult. However, the additional impact about that is it costs us so much money. This is bankrupting the healthcare system. Over 50% of all healthcare utilization comes from the poorest 10% of our population. Our ambulances, our police services see these people on a regular daily basis. They're the same people. They're picking up the same people coming to the emergency department. One of my guys came into the emergency department 191 times in the 6 months before coming into the program. Think about it. 6 months, 191 times. That's a full-time job. You got to think about how you're going to do that. And so that costs a whole bunch. The Toronto folks, Stephen Wang looked at the cost of a chronically homeless person, and you've got, Abe, how many do you have? 400? 400 or 500? The average cost, I think, was $170,000 to $220,000 per person per year. And if they were getting stellar treatment and best care, and that was resolving their circumstances, I guess I might not mind so much. But they get ineffective care and is bankrupting the system. So you could be a hard-hearted economist and really not care about compassionate care for vulnerable populations. You cannot ignore the fact that this is costing way too much money to the healthcare system. It's dominating our police services. Our paramedics are spending most of their time caring for these populations. And I have to say, it's kind of ineffective. So, before I move to inner city, the other thing you have to know is, at least this problem's not getting worse. Well, the reality is the problem is getting worse. Social inequity in Canada is growing. And with social inequity growing, health inequity is going to follow. And it's estimated that this is probably bigger than the aging population, the challenge that we face in our healthcare system. Is anybody talking about a gray tsunami for the poor? It's just not happening. But it's estimated that the cost of the healthcare system, and he just put up some costs there, the estimated cost of the healthcare system is expected to be around 20% of all healthcare expenditures because of growing social inequity. Over the last decade, the rich, at a time of restraint and recession, the rich's total income have gone up 40%. The lowest and the most vulnerable of our communities in the lowest socioeconomic bracket, their income has gone down by 150%. So, increasing gap, progressively getting worse, our Gini index is deteriorating, and with that will become increasing health inequity. And that's where we find ourselves. So, these are the different principles of health quality, and the one that we've neglected the most is the last, inequity. And if we're going to define how we provide services in this context, we're going to have to provide different models of care. And you've heard about that today. We have to start thinking about our roles and our responsibility to advocate for that population. That's what Ryan does so effectively. And we have to think about different models of care, which Naheed has shown us how we could do end-of-life care in a different context, out of a Honda. Sounds pretty good, actually. Nevertheless, we're going to have to define the nature and the extent of the community involved. If we're going to treat vulnerable populations, we better understand them. Here's the social contract with the university. Where could the university play a role? The university could help us define who those populations are, where they are, what are their unique needs. And then we have to consider barriers to them. So we have to actually ask them, what are the challenges that they face in getting health services delivery? Not ask us, ask them. We're not telling them. All of you know that. You've worked in the shelters for long enough. I didn't know that. I thought I was going to go down to the shelters, give out some antibiotics, treat some TB, and that'll be cool, that'll be great, and then I'd be done. And the model that I thought was going to happen is totally different when they started to tell us how it should be. We listened, and that was the one good thing we did. And I'll explain that in a minute. So we have to think of how do we engage those communities, how do we have to provide care on their terms, not on our terms, hence care out of a Honda. We're going to make this a slogan for you. Pretty soon we're going to brand this Honda Care, something like that. And then we have to think about what are those factors that we have to mitigate in addition as we provide the care to allow them to move away from the circumstance where we're providing care and they're a vulnerable population to a population that gets the usual entitlements that they deserve as any other Canadian. And then, of course, we better define that and measure it and publish to it. Because if you don't have data, the one thing I've learned is it doesn't matter. So, in that context then, let me tell you about what we've done in Ottawa as a collective. And this is by no means me. I was just sort of being dragged along. Ottawa's not that different than Calgary when I talk about it, but we have, where it is, these are the numbers over a course of a year. You can see the breakdown. It used to be 15, 20 years ago when I started in the shelters, it was the domain of the adult male alcoholic. Now we've got children, families, elderly individuals. We have to provide palliative care. We have refugees. We have a different cohort of individuals totally. And combined with that, we have differences in their circumstances. Housing is different in Ottawa now. Social services are different. They've been cut back, and just like all of the things that you experience on a regular basis. And the biggest thing that challenges me every day is I'm trying to react to the next addiction du jour. We went from alcohol, Purell, all the guys would march out to the Parliament buildings first thing 8 in the morning because the Parliament buildings discovered Purell, and the guys discovered it right after that, and so they would clean out all the Purell at the Parliament buildings, and so we were dealing with non-beverage alcohol, and then crack cocaine hit, then street opioids, then crystal meth hit, and now it's all about heroin. And so it's different by the community. Every community has its own unique characteristics, but that's the reality of my world. It's a rapidly changing world and one that I have to adjust to on a regular basis. When I think of what we have to do is we talk to our homeless colleagues and we ask them, what were the challenges you faced? And it's all the things that you think about. Transportation. So I had one of my guys into the hospital just recently, and he had cancer and some renal impairment and some diabetes. And when he left, he was on a whole bunch of different medications, none of which he could get anyways, but so it didn't really matter that they all have interactions with each other, so couldn't get them anyways. At the same time, he left with 4 different appointments for 4 different specialists, all at different times, different places. He had to do this, he had to do that, he had to follow a certain diet, etc. And it was as if this guy looked at this stuff and said, you know, what planet are these guys on? Do they have any idea what my reality is? So no meds, no diet, no home, no follow-up, no transportation. So basically thanks, but no thanks. So these are the other challenges, and I really wanted to talk about the concept of health. Our concept of health is one where you plan for your health, you kind of think that, well, this is, you know, I want to make sure that I'm healthy, I'm going to eat healthy, I'm going to exercise, all those things Ryan told us about. This is not their world. They're dealing in one crisis to the next. The crisis of their addiction, the crisis of their mental health challenge. An appointment at 9 in the morning is useless. They don't have enough money for a cab drive to get up to or even a bus fare to get up to the hospital. They're dealing with their crisis. And when their health crisis gets louder than their mental health or their addiction crisis, then they will come to our care. And somehow, rather than expect them to change, this is what we do, we expect them to change to fit into our system. What we have to do is figure out a system that serves them based on the reality of their lives. And I can tell you, health promotion is not something they're interested in. So let me go ahead. We got together probably 20 years ago. We started off really small. We had all of these different health care providers. We've actually now developed a community of people who have rallied around to try and solve the problems of health services delivery for the homeless. We actually probably have another 5 who are, but these are formal members of our board. And so these are the people who run inner city, not me. The service providers, the people in our community run inner city. I'm an employee of theirs. We started off very small. We've grown dramatically. We're about the size of a medium-sized hospital now. We're about, I did rounds this week, we were about 240 inpatient beds. We have, about 150 personal support workers, about twice that number of volunteers. We have 12 nurses, 4 nurse practitioners, and 1 doctor. And I'm half-time. This is driven by the people who really know how the reality of these individuals' lives. It's a totally different model of care. It's totally team-based. On the members of my team are paramedics, police officers, people who deal with housing, the judicial system. Those are the people I talk to. We don't talk as much about tuberculosis as we do about warrants and diversion and housing. So we've grown. We're now 9 facilities across the city. And the model we've said was, we're going to put our services where the homeless are. We're going to come to them, just like Honda Care. And so what we've done is we have managed alcohol program, which I can tell you about later, and I will in the workshops. We stole that unabashedly from Toronto. We have a diversion program, which I'll tell you about in a moment. And we have special programs. We have a hospice, which Naheed mentioned. We have hotels. We've now got 4 hotels. We find people under fields and under bridges. And it's a coordinated, integrated program of bringing people out of the cold, providing them shelter, and in that context of supportive housing, we provide them services. And it's amazing when you bring them in and then say, you know, let me deal with that foot of yours, and couldn't I help your mental health? And by the way, we can deal with your addiction. But you can't do that if they're crazy, in crisis throughout the city, and you can't even find them in a half an hour. You have to have a home for them. May not be a home in our terms, but it has to be a place. So that's what we chose. We chose structural facilities where they could call their home, and we wrap services, integrated service programs around the individual. And you can see all the locations that we are. And I'm just going to talk to you a little bit about one program. So access the right care, the right place, the right time. And these are all the programs. We have a managed alcohol program where we thought we made every mistake going. Trust me. You can never think of all the mistakes that you could make that we haven't made twice. So we had a managed alcohol program, so we were giving alcohol to these guys. That stabilized them. And then they said, we don't want to be here anymore. We want to be in stable housing. We want to be with our family. We want a Christmas party. We want to have a garden. We want a dog, and we want to cook for ourselves. And we said, it's kind of a good thing to do, but we don't have that. So then we suddenly, the back end, we never thought of the back end. What happens when you become into an acute managed alcohol program? What's next? We had to scurry around. We had to buy a hotel and put them into that supportive, stable housing. We still found many people coming into the emergency department. Our police, our paramedics were bringing those individuals constantly to us and into the emergency department. We had to do something. So we asked all of them who these people were, and we found out that, in fact, as you might have gathered, there's about 100 guys who are on a regular basis coming in and out of the emergency department. So we said, all right, we'll go find them. We'll tell them to come to us. Don't go to the emergency department. We'll ask our ambulances and police to bring them to us. We'll have a unit where they're stabilized, they sober up, and then the next morning when they're sober, we'll actually say, hey, how about that foot? Can I help you there? Why don't you come back to us? Why don't you come into a managed alcohol program? Or do you want a detox? We'll do that right now. Not in 6 months, right now. How about being part of our community? And how about not going back to the emergency department so that next time you're coming to us? We thought that was better care. Might even save some money. We were funded for 150 diversions. As you can see, true diversions, there are many more people came to us, 618. It was starting to get a bit crazy. Next year, 5,320. This is Mad Max in the Thunderdome. This is 45 beds, drunk and disorderly, everybody in Ottawa. They're coming from the transportation system, they're coming from the Rideau Mall, our police, our ambulance, diverting all of those individuals. Our nurses love it. Best place to work. They just think that this is ideal for them. These are the most dedicated, spectacular people in the world. But you can imagine how challenging this environment is. So those people, and when you look at it, you can provide better care. Nobody got sick. We had to phone the police on 3%. We had to phone the, on 2%, and the ambulance again on 3%. They dropped them off. They deteriorated on their vitals. The police, we said this person is now sobering up a bit. He's becoming very, very challenging to manage. And so we had to phone the police back on 3%. The rest stayed with us. Nobody got sick. Everybody got better care. We just saved the system $1.7 million. So that was our cost. So Can you provide better care? You certainly can. Do you have to wait for permission? No, you don't. Just do it. You are empowered to do this. And you can make an enormous difference to the lives of these individuals and to the healthcare system itself. So, I'll end with this just to say, what's our role? And this reflects all of the discussion, and it comes back to my initial comments. We can create information for a healthy social policy decisions. We have a university who, you're very fortunate, who is dedicated to this. I think that that should be the role of a university, reaching out into their community and provide meaningful research that provides evidence and data to drive social policy. Promote effective health delivery systems for prevention and care. We, as providers in all levels, can do this. We can get involved in advocacy for anti-poverty measures. That's Ryan. We can affect positive social change through healthy social policy. We can create that healthy social policy, and we can promote it. And then we can advocate for the values that are essential for health and healthcare within our community. These individuals are members of our community. With great wealth comes great responsibility. I don't think that was Spider-Man, it was John F. Kennedy, actually, but, but nevertheless, having said that, we have this opportunity. We have this responsibility. And so I'd hope to engage all of you in that discussion about how we could do it in your context. And this is just a whole bunch of different pictures. We've had weddings and funerals, and we have Christmas parties. They come to I live on a farm. All the homeless guys come up. They've already told me when they're coming up to the farm. They're going to cut a Christmas tree at my farm. Homeless alcoholics, chainsaws, you might think is not such a good idea. But nevertheless, they've already defined who's going to be doing the chainsawing. But we've had artists, a rich number of fantastic people, which I suspect each and every one of you would think you have your own examples of people who have wonderful expertise in histories, tragic, but equally wonderful. So I count myself very fortunate to be part of that community. So I'll stop at that. And then I think we're going to ask questions now, aren't we? Yeah?
Hi, everyone. My name is Van Nguyen, and I'm a family doctor at CUPS, and I also work a little bit at the Alex as well. And I'm also the health director at CUPS, and I just want to say that after this morning's very inspiring and amazing presentations, my mind is just so full of inspiration and neat and wonderful ideas for taking it back to Calgary and in the context that I work in and trying to apply it to the folks and the folks that I work with, in addition to the teams that we work with as well. So I want to thank the speakers again for their amazing presentations this morning. So we would like to start off the Q&A session with some questions from the audience, and we have some wonderful medical student volunteers who are doing the running around with the microphones. So if you'd like to ask a question or even provide a comment, please do so and raise your hand, and we'll have the medical students come to you. So perhaps as you are gathering your questions, I can maybe start off with one myself. We talked a lot about community engagement, and you know, it was really neat for me to have each and every one of you talk not so much about higher level things that we should be doing in terms of advocacy, but also at the level of the patient, and sharing your wonderful stories about patients and the good work that the community agencies are doing to come together on behalf of the patients to sort of bring forward advocacy and change. How do you know, there are lots of agencies who are coming together and doing good work in terms of case management plans, because that was mentioned in particular in Dr. Dosani's presentations. But how do we sort of engage and communicate well with acute care in terms of communicating case management plans at the community level? Is that challenging, or have you come up with strategies or solutions in your particular contexts to make that easier, you know, when there are privacy issues and different EMRs? And I know that question can be applied across each of your three situations. So maybe if we want to start with Dr. Dosani.
okay, we'll make it work. Actually, I think this is a big issue, and medical records and siloing of medical records is a big concern. And in the Ontario context, we don't have a shared electronic medical record system. So when I'm in the community charting on our each Oscar, which is the name of our EMR system, the patient has a crisis and shows up in the emergency department. If they're not coming with a letter that I generated, there's no sense of the diagnosis, the addictions issues, mental illness, or the medications they're on, which is like big time an issue. And so in a perfect world, we sort of have an integrated information system. One thing that we do is we leave a letter with all our patients. So a simplified, if you're hospitalized, this is a document that you can present that's general enough, and we try to put it in their wallet or their pocket or in their room. If anything happens, try to give it to their caseworker. We have workarounds. I'd love to hear Dr. Turnbull's thoughts on this, because when we talked about this in Ottawa, Wendy Muckle actually spoke about some of the strategies about integrating medical records with Ottawa Intercity Health and the hospital system, and I think there's an opportunity to sort of build some connections and relationships.
So, thanks, Nate. Wendy Muckle is a force of nature, and I think of myself as just being sucked up in the fumes behind Wendy as she goes by. So for those of you who don't know her, you should really get to see her. Wendy is, and we recognized very quickly we had to connect better with all providers, so we have one medical record. We also, that medical record is available to the emergency department and to our ambulance services. So the medical record, Oscar, the Emerge docs have a complete view of that. Nobody goes up to the emergency department without a dossier of what our concerns are and a phone call to the emergency department. And in addition to that, the other thing we did, which is actually brilliant from Wendy, was we actually have cards, intercity ID cards. We need this because in Ontario you have to have photo ID for opioids, but the ID cards identifies them as an intercity health client. That means when they're in the emergency department, that means that they have to click onto our medical record. And at the same time, because of the triage bypassing the emergency department, when they have that card, that means they're ours. That means they come to our shelter. They don't go to the hospital unless we send them up to the hospital. So when they're found intoxicated in the Rideau Mall, if they have that card, they come to us. And they've given permission and consent for that. And of all the things that a homeless guy will lose, I thought it was going to be gone in 30 seconds. Nope, they don't lose the cards. It's funny. They'll lose their wallet, but they won't lose their card.
But what about discharge, right? Like discharging a homeless or vulnerably housed person who has social services or case management is one of the most challenging things to do. And I think sometimes we find that folks are discharged to women's residence or Seton House, with medical plans. It's not a hospital, it's a shelter, right? And like there's this context of like the folks in the healthcare facilities don't understand what we can or cannot do. So I think there's a lot of challenges on discharge. We need a better form of communication, absolutely. I think that's a problem we're seeing across the country.
Maybe we'll let Dr. Meili comment, and then I know we've got a question from Alana.
I really appreciate that question, because the interfaces of communication are one of the biggest challenges for working with marginalized populations. Some of the things we've seen helping are the hub model in Prince Albert in Saskatchewan. They started doing that with the police and the healthcare service and other social services meeting daily just to talk about. They talk about individuals, and then they talk about that individual's family to see what else is going on around them, and identifying high-risk families that they discuss and try to seek out before more people in that family get into a crisis if one member is, or try to avoid crises. We do something somewhat similar with our HIV care, where we have a regular communication, but also a weekly meeting where we have people from the hospital, from social services, from the different aid service organizations, as well as our clinic, meet and go through our list of high-risk patients. That's really helpful for the people who are already HIV and in case management. It's not so helpful for the people who are the next group. So that to me is one of the big challenges as we think of all of these different hub and hotspotting and other models, is not just identifying who's already using services, but how do we move upstream from that and think about who's going to wind up, who's at risk, and how do we connect with them. three of the interfaces that really we struggle with. One is hospital, and it's less so, not too bad with discharge and admission, because it's a small enough place that we know the other providers, the docs that we're admitting with, and we'll have some communication. It's the numerous people going through shift change, some of whom are well trained to work with a population that's more challenging, and others, like the nurse that you described, that struggle more with those challenges. The other two that I think are interesting to think about is prisons. We have a terrible time people going into prison and getting off care, coming back and having changed care but getting no communication, and trying to do the detective work to figure out what happened while they were incarcerated. And then the third is just lost to community, where we have people that don't have phone numbers, that don't stay in a shelter, they just are moving around, and how do you track them down? We're fortunate that our receptionists at the Westside Clinic are very community connected. They're all First Nations, and they refer to themselves as being tapped into the moccasin telegraph. And so if we've missed somebody, they can often get them, but there are certainly people, especially those who are new to a community, just coming through in transit, that's the one that worries me the most, is not lost between the institutions, but lost between any connection to care and out in the community.
Thank you. We have a question from Alana. Alana works at CUPS as a nurse practitioner.
Hi there. This is a logistical and operational question for Dr. Turnbull. Can you describe your diversion facility? 24 hours, what's your staff mix? How do you operate like in a real-time way?
Thanks very much. So the diversion facility is at one of the shelters. It's at the Shepherds of Good Hope. It's 45 beds, of which 4 on one side and 4 on another are acute and observed beds. The other one are, if you're stable and it's not an issue and it's just a matter of sleeping it off, you'll go to one of the dorm beds that we look after. But if you're somewhat unstable and you need better observation, well, we have 2 observation units with glass walls that we can actually see all the people inside. And we have opportunities to monitor them with ECGs, oximetry, all of the other requirements. The staffing mix, we started off with trained personal support workers. We've recognized that's not sufficient, so now we have nursing staff 24/7, and we have backup with myself being the physician. So, and to date, it seems to be working pretty well.
Sorry, Gwen. We've got a question from Dr. Labrie, and then we'll take one from you, Gwen.
Thank you very much. Among other hats, all of his other hats, one of the most unsung ones that Dr. Turnbull has worn has been the Senior Medical Advisor for Corrections Services Canada for a long time. And I'd like to ask a question around that. Dr. Meili mentioned the issues around prisons and communications around prisons, but particularly Corrections Services Canada is probably the largest mental health and mental illness institution in Canada. And no addictions, relatively speaking, no addictions care, limited psychiatric support, and no capacity to work with communities to be able to do that, to be able to make sure that people can be reintegrated into the community, and 98% of those people in corrections and federal prisons will be back on the street. And it's not just CSC, it's all of the provincial jails across Canada really don't have that capacity. What can we do to be able to advocate for integration of those activities into that larger community?
So thanks for that. We both share that same challenge in that our provincial and our federal prison systems are, in fact, the home for our deinstitutionalized mentally ill and individuals with drug and alcohol addiction. We've reinstitutionalized them in another context. And one would think that if you had this environment where you have those individuals in a stable housed environment, you might be able to start to work on many of those challenges that they have, so when they do come back, they don't immediately become victims or commit further crimes, and then recidivism rates would be very high. Unfortunately, recidivism rates are huge, and this is just a progressive escalation up an increasing ladder that begins with charges, then into your municipal process, then into your provincial process, then when it's 2 years plus a day, you're into the feds, and then that will continue often as your sentence continues. We, unfortunately, are not getting ahead of that. The challenge that Correction Services Canada has is that they try to reach out to communities sometimes, but what they'll often find is somebody will be paroled like that, and they have to leave that day. And the challenge is then they're scurrying. And often the receptor is not out in the community that easily, where you could say, well, would there be effective drug and alcohol treatment programs or ongoing counseling with psychologists, psychiatrists, and their appropriate medications? That's often not there. The communication and the connection is very poor, often hurried, and then we're surprised when those individuals within 2 weeks are back with me in the shelters again and committing the same type of crimes they were doing before after 3 years where I thought they were getting reasonable care. Huge problem.
Thank you. Yeah, that's certainly a huge problem here in Calgary as well, and I'm sure in other places as well. We have Gwen, who's a nurse practitioner at CUPS.
I think in Alberta we have one benefit that we're not tapping into when it comes to communication with the hospitals and social services. Netcare, if we only used it properly, that had the primary care provider listed listed all the time, and then if they put Gwen Moncayo, nurse practitioner at CUPS, then somebody from Emerge would have the ability to say, oh, I bet that they have something going on, and contact us. But I need everybody that has Netcare access to be going on the left-hand side, and there's a place where you can put your improvements in. And they say that the squeaky wheel will get the grease. So everybody put that we want the primary care providers and their working place to be added to Netcare, so then communication can be improved for case managing these patients.
It would be great. You could also have the primary care provider or the clinic update their medical record, surgeries, any recent procedures, med changes, because that's something that's completely lost. You have your complex patients arriving at the hospital with, they have no information, they have all these medication changes that maybe weren't necessary. And they come back confused, different meds, you don't know what to resume, what to start, what to discontinue. We could utilize the system better.
If you could just state your name and where you're from, because
I'm Kendra, was an Ottawa grad, so that's always exciting, and now a family medicine resident. Just wanted some words of wisdom for any new healthcare professionals. In 6 months, hopefully from now, I'll be working with some of these populations. Just what are your words of wisdom for a new healthcare professional?
Ryan.
Okay, I guess I'm in the middle of the professional stream here. That's a tough one. What are some of the pieces of advice? I was we're doing a project where we have medical students interviewing people who are interesting doctors around the country, and in my conversation with the medical student, she was talking about being overwhelmed right now with all the clinical information and also trying to maintain this social mindset and keep an eye on that. And my advice to her was to prepare to be successively overwhelmed by new things, and that really there are just repeated learning curves. I listened to Dr. Turnbull talk about some of the lessons he's learned those are lessons I look forward to learning someday. I'm still stages behind. And to have some patience with yourself. You know, we are demanding a lot of ourselves to be advocates at micro, meso, and macro levels, to be excellent medical experts, and to recognize that there is a season for everything. And right now, you know, passing that exam is a really important thing to do so that you can actually be there. The one thing I do try to encourage learners at all stages, though, is to try and at least maintain, no matter how wrapped up you are in the clinical training and academic life, is try to maintain some connection to community, to practice, and to advocacy for underserved populations, because it's in those later stages of residency and fellowship where we get so wrapped up that we lose track, and it can be hard to re-enter in practice. So it's tough to find the balance, but if you can manage to, at the very least, maintain some connection, whether it's the odd shift at the student-run clinic or something like that, so that you keep in mind the vision of who it is you're here to serve in the first place, then it's far more likely that you'll actually maintain that into practice.
I think being a trainee is hard because you're away from the processes that typically are involved in making change. Like, when's the last time you were invited to be on a committee at your hospital about social accountability, for example? There's a lack of transparency, and even if you want to do something, there's so much inertia, but by the time you get it started, you've graduated already, right? So it's really tough, right? So one of the things that I tell medical trainees who work with us is let the patient voice guide you. If you really are listening to your patients, I mean really, like listening to their struggles around, and Dr. Turnbull talked about appointment times or how I get to my appointments, the transportation, or you know, nobody's listening to what I'm really saying. If you really listen to the voice, that will guide you. And when you listen to that, you start to realize that we are trained within certain particular structures. This is a CTU, and this is how it works. This is a family medicine clinic, and this is how it works. No. Let's meet them where they're at, and let's break down those structures to meet people where they're at. If there's one thing the Ottawa group also taught me as just a third thought, is data. And I think Dr. Turnbull talked about that, is collect as much data as you can and learn from people who've done it before you about what is the important data. Because you can have the stories, and they're really emotional, and they're really cool, and they tell a narrative, but the data drives those stories home. And I think those are just some three different thoughts to think about.
I guess my advice would come from the amount of gray hair I have. It's really not gray, I dye it gray. It's really just giving you that more distinguished appearance. I would say that throughout your whole career, people will try and push you away from serving these communities. There will be all sorts of incentives for you not to do this. But I would ask you never to lose that sense of compassion and passion for what you do, but also that sense of service. And I can't tell you how important that is in your career and your personal satisfaction. I love my job. And I'm so glad that I've continued to do that despite all of the other efforts to push me away from that. So I would not want you to lose that sense of meaning in what you do.
Thank you so much. Inspiring words of wisdom. I think there was a question at the far left, and then we'll go to that person, yeah? My far left.
Hello, my name is Herbie Gill. I'm a family physician. I'm also a hospitalist at the Peter Naheed, which is one of our hospitalists there, and I'm the site lead for the hospitalist program. Just before I get to my question, Dr. Labre's question was very, very well placed. One of the best ways I've heard it characterized is pipeline to homelessness. There's the criminal justice system is one of the great pipelines that just keeps supplying this, and we really have to, you know, it's not enough to just address that, but I think you got to stem the pipeline. The other one is when children come up through foster care. I heard that on that wasn't me, the CBC radio, loved CBC radio. My question is, in medical services and social services for the homeless and the marginalized are very siloed. I don't know if that's just a Calgary phenomenon. I suspect probably not. Navigating these silos is a very hard thing as a discharging physician. So when we're discharging patients to the community, accepting patients into inpatient care in the clinic, homelessness isn't only downtown, it's in my Northwest family practice as well as in some of the most affluent areas, homelessness is omnipresent. I'm curious what your guys' thoughts are on breaking down the silos. I don't know if unifying everything under one common umbrella is the answer, but how have you done it there?
Who wants to start? That's a tough question.
It is a very tough question. It's a tough question because of service delivery models, but also funding. Because any savings that you might make will be accrued by another population, another group. And so you might save them in a certain area, but somebody else gets the money. So the challenge of that is to bring those people in a programmatic structure. And some governments have been trying to work on poverty reduction programs, and those programs bring together the silos and work together. That's at a governmental level. At a service provider level, when we do on Thursday mornings, we go through the list of all of our patients and our clients that we're providing services for. Around that table is a police officer, is a social worker, is a housing person, care providers, shelter people, and it's a team approach, and so that's how we do it at an individual level. And we are owned, Intercity is owned by all of the community, all of the providers. Social services sits there, judicial sits there, our ambulance services all sit there. So it's a conscious effort to try and break those silos in a programmatic fashion. It's probably one of our biggest structural barriers that we have to deal with, so you're exactly right. We don't do it perfectly. But at the hospital, when you discharge somebody, you just discharge the social worker at the hospital, just phones Intercity, and that's it. One number to call, we look after the rest. Makes it easier.
I guess I come at it from a different angle, sort of just having graduated, been a trainee, and then working with a urban health organization where folks have clearly been doing palliative care for a really long time and saying, hey, we can do this, a different way, or what, have you thought of this, or have you thought of that? And we have to be so careful. There's so many passionate people who do urban health or work with marginalized populations. We have to be careful to not further marginalize the marginalized. And in some ways, when we create these silos, are we actually disconnecting them from mainstream support services? A really practical example is at Seton House, the men who are dying there had been so well supported by urban health providers that they weren't getting referred to home palliative care services with home care. And why not? They're told they have a right to that service, and actually they would get more supports if they were. And that's part of the kind of structural work that we have to do. We have to be careful that we're not doing that. I mean, in a perfect world, there shouldn't be a peach. It shouldn't really exist. It should be existing within existing palliative care services. There shouldn't even be an Intercity Health. It should be existing within other services. We need to build capacity. And that's why in Peach, the education comes before care. And that's why, being here, this is part of what we're doing, is trying to work with folks to build that capacity, make them feel comfortable so that everyone's doing this and we're not marginalizing the marginalized. We have to be conscious of that because our passion can take us to that point, and we have to be careful.
I'm just having a look at the time, and we're running right on time, but maybe I'll just allow one more quick question.
Brian Cornelson, I'm a family physician here in Calgary. Dr. Turnbull, you were talking about the reaction of the Minister of Health, and basically indicating that they were there to be led. And we're now in a very unique situation where the Minister of Health and the Minister of Aboriginal Affairs are both family physicians. And so it strikes me as an amazing once-in-a-lifetime opportunity. How are we going to pursue that?
I think if there was one thing that came out of today would be you've got the people here I think if those people approached, plus some others, and I would add in some others, I think representatives of the communities, representatives of the different communities who are actively involved. I would think your Rotary, your church groups, your faith-based organizations, your shelter organizations, if they came together and developed a roadmap, a strategy, and brought that to the ministers, of which, you know, they would have a great deal of sensitivity. I think that that's the recipe for going on. I think the first thing they'll say is, no, that's going to cost too much money, and at a time of enormous restraint. And I think what you have to do is say, hey, we're in the business of saving you money. And you may not accrue it immediately, but you're going to see this, there's a return on investment. And if we had a School of Economics that worked with our Faculty of Medicine, that School of Economics would very quickly show you the massive return on investments that any industry for that type of investment would jump at. So I think we could go to them with creative solutions. You've got an ideal window. We also have a Minister of Health who is a physician. And our Minister of Health has spoken very clearly about equity as an important driver for the economy, for the well-being of our overall community, and for those people affected so much. So we're also trying to think about how we could capitalize on this. So when you figure it out, let us know.
Ryan, would you like to close and maybe comment on that question?
Yeah,
given your role.
I'd like to comment as well, for sure. Jane Philpott's a family physician who worked in Niger for 10 years, definitely has an understanding of global health, of inner city health, and of the social determinants of health. Carolyn Bennett also has talked a lot about social determinants of health and even health in all policies in the past. I think there's lots of things we should be asking for, but I really would encourage lots of people to start thinking about this notion of health in all policies, because it's the type of approach that could influence health far beyond just the Ministry of Health. If we could actually get all of the different ministries seeing their primary goal as the health of the population and investing in approaches to income distribution, approaches to the environment, approaches to transport and education that really are seen through that optimization of health equity lens, that has the power to not only see us change the policies of this current government, the particular policies around healthcare or spending and current budgets, but actually create a framework, a foundation for how we look at policy overall into the future. So certainly that's what, through Upstream, we're going to be talking to those ministers and Minister Hoskins in Ontario and others to try and advance that as a potential cause. And that's part of what we're doing, trying to bring bringing Michael Marmot to Ottawa in April, is try and get that on the public agenda and on the minister's agenda. So again, there's a big menu, and I don't want to limit people's ideas, but if you can keep in mind as you're doing your own advocacy, that notion of health in all policies, the more voices they hear that from, the more likely we'll be able to make that significant, really groundbreaking advance.
Great, thank you. Thank you to our speakers once again, and I'd like to turn the mic back to Jennifer, who will close the morning.
So, again, thank you to our panel and to all of you for being here. It's been a remarkable morning. I am left with this notion from Ryan around the practical frames, which I think using health in all policies, if it can become a mantra that we're all talking about, I think that's so critical. The other thing that I'm excited about as I listen to Naheed is this nimble responsiveness, this dynamic responsiveness, and the way in which he's calling us to action. The theme of teams was very critical all morning, and I think that as you move into your work this afternoon, thinking about how the teams can work together. And I am also called to action by Jeff around the social contract for universities, which I feel very, very deeply and I am utterly committed to. So I think what we are left with after a remarkable and stimulating and exciting morning is that we are all leaders.